Good morning from Miami Beach. This is Dr. John Bennett, Neurosurgical TV. We have the pleasure of having Atul Goel with the Spine Revolution. And I'll start, let me just tell the audience that you can see this broadcast if you download the app, Neurosurgical TV. It's very easy to see. So let's start the proceedings. Let me introduce Yoon Ha, a spine neurosurgeon from Korea. Welcome, Yoon.
Hi, nice to meet you. So I'm very honored to moderate this session. So as we know, Dr. Atul Goel is a pioneer of the spine surgery. As we know, he developed many kinds of new concept and device, instrument, knowledge. So I believe his lecture today is really inspiring the surgeons in the world. So let me give a short introduction of Dr. Atul Goel. He's now the professor and the chief head of the Department of Neurosurgery, King Edward Memorial Hospital and SIS, GS Medical College in Mumbai, India. And he has a lot of publication, book, chapters, and also he is a editor-in-chief of craniospinal surgery. And he is also doing a lot of contribution to neurospine. I work for neurospine as an editor-in-chief. So he provides his new concept of knowledge, and he evokes many debates in our neurospine journal. So that is a really fantastic and very informative debate. So I'm very excited to moderate this session. So please, Dr. Goel, give your knowledge and a new concept to our spine society. Thank you.
Oscar?
Yes, Atul. So it's really my pleasure to be present here and announce Atul Goel. As Dr. Kons said, almost everything is really a gift and talent and innovative neurosurgeon. And what I really like from Atul that he inspires me, he's not only a great spine surgeon, it's also a brain spine surgeon. And I think brain and surgery and spine, they go along together and can benefit from concepts from one side and the other. So I learned a lot from Atul, and I think especially for young people, this will be a very challenging and innovative lecture. Please, Atul.
Thank you, Oscar. I will like even Vlad to say some nice good words to me. Vlad?
Sure, I will. That's an honor to introduce you. I don't need to introduce Atul. I believe that he's one of the most prominent neurosurgeons of recent times. And what I enjoy always with him is that there are new concepts, new ideas, and some fantasy and creativity, which I always enjoy because he's one of the few neurosurgeons who really are pushing neurosurgery forward. And I'm looking forward to the lecture, Atul, very much.
Thank you, thank you. Thank you, Vlad. So you can see my slide, John?
Yes.
Yes.
Okay,
yes.
okay. So I'm going to talk to you about spine surgery and maybe something new about spine surgery. As we know, spine surgery is very common surgical procedure all over the world. In every nook and corner, spine surgery is done. So everybody knows about spine surgery. And if there is something different, it will actually change quite a bit of a scenario in this field of surgery. So I'm going to talk to you about a new concept. And this new concept is, which I believe is an absolute game changer in this field, that in most of the issues that face a spine surgeon, instability is the issue and stabilization is the treatment. If you really think about it, currently everybody thinks that compression is the issue and decompression is the treatment. So what I want to talk about is that compression is not the issue. Decompression is not the treatment. Instability is the issue and stabilization is the treatment. So that is the crux of my lecture. Now I want to show you these three animals. This is a four-legged animal, and all the muscles are located in the hands and legs. There is nothing much in the spine. You see the strong muscles of the hand and legs. So if these muscles become weak, the animal will not be able to run that fast, and animal will not be able to conduct its main activity of running and holding. This bird is having very small legs and small muscles and almost no hands. But the hands are in the form of huge wings, and all the muscles are located in the wings, and the entire activity is located in the muscles of the wing. And if these muscles become weak by its activity, then the animal will have difficulty in flying. Like if the muscles become weak, the animal will there will be difficulty in running. As regards human being, it is a standing human position. Of course, these muscles are much stronger than a normal human being. Standing human position is the main issue. And all the muscles of the spine are located in the back of the spine, in the extensor, which make the human being stand. So all the muscles are behind. There are hardly any muscles in front of the spine. So my concept is absolutely clear that weakness of these muscles of the back of the spine is the nodal point of genesis of all spinal problems. So what is mandatory for us is that we should take care of our muscles. We should strengthen our muscles. If we do not strengthen our muscles, our spine will give way and we will not be able to stand. So body, human body and animal body is made so that it can function throughout its life. The problems will occur if we do not take care of the gift that God has given us and we do not exercise enough. So weakness of the muscles is the main issue. As the human body is standing human body, the concept is that vertical, you see the vertical, as the muscles become weak, there is telescoping of the spine, and this vertical fascial instability is the point of genesis of cervical or lumbar cervical spondylotic disease. So before I go on degenerative spine, I will like to discuss few issues about craniovertebral junction, not the whole lot of craniovertebral junction, but few issues that are relevant to the understanding of degenerative spine. Basilar invagination. You see, many of the people in the audience I know are quite young, and they might not be knowing what was happening 20 years ago in the understanding of basilar invagination. Basilar invagination was not understood at all, essentially. And decompression was the treatment. The problem at the craniovertebral junction was related to fixed atlantoaxial instability. And because it was fixed, decompression was the treatment. Compression was the cause and decompression was the treatment. That was the policy 25 years ago. In 2004, we introduced this concept that there are two groups of basilar invagination. In one group, the odontoid process goes in, and in group B, the tonsils herniate downwards. Earlier, the concept was odontoid is compressing, so you remove the odontoid. The concept was tonsil is compressing, so you do foramen magnum decompression. So this was the concept. In 2004, we introduced that this group, not this group, needs is an unstable spine. It is not a fixed spine. Instability is the issue. And we introduced a very fantastic term called craniovertebral junction realignment. So for this group, we said that there is no need for decompression. Instability is the problem and stabilization is the treatment. Now, all those people who are dealing with craniovertebral junction know that decompression is no treatment for this problem. Of course, we did not mention decompression as not a good treatment for group B basilar invagination. So this is some examples. This odontoid going in, the concept was it is compressing the neural structures and you do decompression. In 1980s, the concept came and which became very popular. Anterior compression means anterior decompression. Posterior compression means posterior decompression. This concept became very popular in 1980s, and transoral surgery became a very commonly discussed surgical technique. So this introduction that open the joint, distract the facet, and do craniovertebral junction realignment has completely changed that concept of treatment, and transoral surgery is completely a historical operation. So now over the period of 20-25 years, we have got several hundred cases where this kind of basilar invagination is treated by craniovertebral junction realignment. Instability is the issue. Muscle weakness of the nape of the neck or muscle injury is the problem, and stabilization is the treatment. Craniovertebral junction realignment is an added advantage. Basically, instability, stabilization, no decompression. So that was my concept. And now you know that this concept has become quite widely popular. This was in the year 2000, first case I did where I did craniovertebral junction realignment, and subsequently there are at least 1,700 cases of this kind and total of about 2,800 cases of C1, C2 fixation we have done in our department. So open the joint, distract the facet, introduce bone graft, and do fixation. Instability is the issue and stabilization is the treatment. No anterior decompression, no posterior decompression. So Dr. Ha, who is here, the editor of Neurospine, will remember this article. Basilar invagination, instability is the issue and stabilization is the treatment. So this is the current concept. And transoral surgery, there is no hesitation in my mind to say that we completely demolished transoral surgery from the domain of neurosurgery or spine surgery. The other thing that we talked about and has become quite popularly understood now, I talked about facets. You see, earlier facets were not even seen by plain radiology, even CT scan, nobody bothered about facets. So understanding the facets, there is no doubt in my mind that understanding of the facet, which was first introduced in our articles about 22 or 23 years ago, has now become quite a popular subject. So in 1999, we said that basilar invagination is nothing but instability of C1 and C2. like lumbosacral listhesis, L5 over S1 listhesis due to an unstable spine. Similarly, there is an instability at C1, C2 leading to basilar invagination. So this was the concept that instability is the issue. Here, if you see, there is basilar invagination, there is Chiari, there is syrinx, and there is a manifest atlantoaxial instability. More importantly, there is listhesis of C1 over C2 that you can see here. So the treatment is not decompression. Treatment is not decompression from front or decompression from behind. The treatment is facetal realignment and craniovertebral junction realignment and stabilization. The issue is instability and the treatment is stabilization. So that was my concept. More recently, about 15 years ago, we introduced another very dynamic and very fantastic, and I have no hesitation to say that a revolutionary concept in not only craniovertebral junction, but in the rest of the spine, where we introduced a new kind of instability called central or axial atlantoaxial instability. Central or axial atlantoaxial instability. And we have related this kind of instability to basilar invagination, Chiari formation, syringomyelia, spinal degeneration, cervical spondylosis, OPLL, Hirayama disease. All these things I am going to discuss today in my current lecture. So in 1999, we introduced that there can be listhesis of C1 over C2. This is the listhesis of C1 over C2. There is atlantodental interval disturbance. There is compression of the neural tubes by the odontoid process. There is listhesis of the facet, and their treatment is craniovertebral junction realignment. So this was one concept that we introduced in 1999. The next concept is, you see the facet of C1 can be behind the facet of C2. This kind of huge basilar invagination, the whole world will do foramen magnum decompression. But if you see the facetal malalignment, this is clearly an unstable craniovertebral junction. And there is no question in my mind that this patient does not need any decompression, and you do atlantoaxial fixation. So that is the treatment. Then another very fantastic concept is, even when there is no facetal malalignment, even when there is no atlantodental interval disturbance, even when there is no compression by the odontoid process, presence of various kinds of alterations that include basilar invagination, syringomyelia, Chiari formation, and a host of other problems, which I'm going to briefly talk about. They are indicators of unstable craniovertebral junction, and they suggest that even when there is no radiological evidence of instability, they need stabilization. No decompression is required. Decompression is a negative issue in the presence of an unstable spine. So that is a revolution in the management of these problems. So instability is the issue. And what we have said is, basilar invagination is a secondary natural protection. So you remember this word, that basilar invagination is a secondary natural protective maneuvering. So we have written several articles on this subject, that basilar invagination group A and basilar invagination group B, where we had earlier advised decompression, both of these problems are related to atlantoaxial instability, which is related to muscle weakness And the treatment of this problem is atlantoaxial stabilization, and decompression is not necessary. So you see, even when there is no atlantodental interval disturbance, there can be type 2 dislocation, Chiari formation, and syringomyelia. The requirement is atlantoaxial fixation, and the patient will remarkably, you have to just believe me that the patient, I will show you several patient images also, that the patient will improve dramatically in the evening of operation if you are able to do a good fixation. Good fixation means open the joint, remove the cartilage, introduce bone graft, and then do this fixation. The patient will remarkably recover. That is one thing. And the syringomyelia you see will disappear in 100% of cases if you do imaging after 1 year, and in about 10 to 15% if you do imaging after 24 hours. So the whole system changes. Even when there is no atlantodental interval disturbance, even when there is no facetal problem, presence of basilar invagination, presence of Chiari, presence of various other anomalies are indicators of an unstable spine. No tight posterior cranial fossa. Decompression is a negative form of treatment. Stabilization is the treatment, and that is, I call, a central or axial instability. The other very fantastic thing which I want to relate to you is acute instability. We know that there is muscle spasm, there is pain, and all those things we know very well. But chronic instability, when there is a chronic atlantoaxial instability, there are several natural protective maneuvering which includes musculoskeletal abnormalities or alterations like basilar invagination, neural alterations that include Chiari and syringomyelia, and several other alterations. So now there is no question in my mind, and I hope and I wish that you please do not have any question in your mind that basilar invagination or not, syringomyelia or not, Chiari formation, I do not like to call it Chiari malformation because malformation indicates abnormality. I am saying that Chiari is a natural protective maneuvering. In the presence of Chiari, even in the absence of basilar invagination or any other problem, instability is the issue and stabilization is the treatment. There is no doubt about this issue. And we have got several hundred cases where we have done for Chiari and syringomyelia only stabilization. And this was after 48-hour surgery. You see reduction in the size of syrinx, and after 1 year of surgery, remarkable reduction in syrinx. It is not the syrinx that matters. I have to say that syrinx is a natural protective maneuvering. Chiari is a natural protective maneuvering. They are responses. They are not primary. Chiari is not primary. They are secondary. Compression is not the issue. Instability is the issue, and stabilization is the treatment. So atlantoaxial instability, which is the result of weakness of muscles of the craniovertebral junction, is the primary issue. Basilar invagination, syringomyelia, Chiari formation are secondary problems. Not problems, they are secondary solutions. So this article of mine, many of you know about this article and has become quite heavily cited already. Is atlantoaxial instability the cause of Chiari formation, malformation? I have to say without any hesitation and without any doubt that atlantoaxial fixation is the treatment. And recently I introduced in World Neurosurgery this article with my experience of 388 cases with 100% recovery. 100%, you tell me any other surgical procedure in the world will have 100% outcome, even hernia operation can have problem. Even carpal tunnel syndromes can have problem. 100%. Some problem related to vertebral artery in some of the one or two of these cases, which are all mentioned in this article. We have treated now the other thing that I am doing on a regular basis, and we are getting referrals from all over the world, are the patients where foramen magnum decompression has failed, and then we do atlantoaxial fixation. So I have got a large number of patients where I say that my fixation will give you absolutely new life after surgery. So the basic premise is that Chiari is a formation. It is secondary. Compression is not primary in any instance. Instability is the problem. And God is great. Nature is huge. It introduces this airbag in the cases where there is an unstable craniovertebral junction, and it indicates the need of atlantoaxial stabilization. Other things which are protective, other things which happen when there is chronic atlantoaxial instability is Klippel file abnormality or bone fusions. So bone fusions are protective responses to craniovertebral junction instability or atlantoaxial instability. Bifid anterior and posterior arches are also responses to atlantoaxial instability. They are dynamic phenomena. In flexion, the bifid opens. In extension, the bifid closes. So there is opening and closing of this bifid, and it is a dynamic process, and it is not primary. It is not like lumbar bifida. It is an indicator of an unstable atlantoaxial joint, and it indicates that there is no need for any kind of decompression. What is required is stabilization. So when you see multiple fusions, there is no need for any kind of osteotomy or any kind of maneuvering for the bone. When you see bifid anterior and posterior arches, you immediately have to go and see the atlantoaxial facetal articulation, and you do atlantoaxial fixation, and you have given new life to these patients without any doubt, new life. And that new life is in the immediate postoperative period. When there is assimilation of atlas, when there is C2-3 fusion, they are all indicators of an unstable atlantoaxial joint. You have to do atlantoaxial fixation, and you don't have to do C2-3, any maneuvering of C2-3 region, because these are secondary issues. Now you see this image. This was my earlier article where I said that when there is C2-3 fusion and there is C3-4 compression, you have to do C2-3 and C4 and even C1, C2. Now I am saying, and I am saying without any doubt, that even you are seeing the compression at this level, the problem is not here. The problem is at C1, C2, and these are secondary natural processes. They do not need any treatment. What is required is C1, C2 fixation only, nothing more than that. Idiopathic serings. The other very fantastic thing which I want to tell you is, there is chronic atlantoaxial instability. There can be several secondary things, like there can be assimilation of atlas. There can be Chiari malformation. There can be syringomyelia. There can be C2-3 fusion. There can be bifid. There can be os odontoideum. There can be platybasia. There can be, we know, a whole lot of things can happen. But when they happen individually, like if there is only assimilation of atlas, it indicates atlantoaxial instability. If there is only C2-3 fusion without any other problem, it indicates atlantoaxial instability even when there is no radiological evidence of any kind of an unstable craniovertebral junction. Similarly, when syringomyelia is present in association with Chiari, or without the presence of Chiari, it indicates an unstable atlantoaxial joint. You do stabilization. It is not idiopathic. It is related to chronic atlantoaxial instability, and it indicates the need for atlantoaxial stabilization. Other very fantastic thing is musculoskeletal abnormality like short neck, torticollis, and various other issues are also not primary. Short neck, torticollis, these are responses. These are protective responses due to atlantoaxial chronic instability. You do atlantoaxial stabilization, the neck becomes long and the neck becomes straight. And I have got several hundred patients like this, and there is absolutely no doubt. And I suggest that you all should also have no doubt about the genesis of the problem. Atlantoaxial instability is the issue. You stabilize the joint, everything else will recover. Another fantastic thing that you must know about is like this kyphoscoliosis. Many of these kyphoscoliosis and screw you that many problem is not in the spine, problem is in the craniovertebral junction, and problem is in the atlantoaxial joint. You stabilize the atlantoaxial joint, the dorsal kyphosis will return back to normal. You see, this is after about 2-3 months of surgery, the whole of kyphoscoliosis has returned back to normal, and the symptoms have remarkably recovered. So this is the article that I wrote on this subject. And I am saying that like short neck and torticollis, similarly, kyphoscoliosis and short spine. So these are both natural protective maneuvering. Kyphoscoliosis and various kinds of musculoskeletal and neural problems can occur because of atlantoaxial joints. So you can see the atlantoaxial joint is the father of several problems. And unfortunately or fortunately, this father has hundreds of children, and all these children are indicating who their father is and who needs the treatment. The father in all these cases is atlantoaxial instability. Children will be taken care of. You deal with the father. That is the message in this problem. So you treat atlantoaxial stabilization, the syrinx will recover, the deformities may partially or completely recover, but the patient will recover in the neurological symptoms remarkably in a very early postoperative period. This is another case of kyphoscoliosis, and you see this young girl would have otherwise landed up with several screws and rods, as you know, and this is the issue. So we have treated several children, several adults with deformities in the neck, deformities in the back, with only atlantoaxial, and see the wonderful smiles on these faces. And I say that this boy is now sitting like a king, a person who was not even able to stand. Now I want to introduce another issue to you, which I am getting many referrals from all over the world. The issue is about central or axial atlantoaxial instability as a cause of cervical myelopathy. Now you see this, very carefully you see this, because you will, you know, many of you will, I'm sure you will have in your career this kind of a situation. There is bifid arch of atlas. There is no other problem. There is no compression. So, and the person comes with severe disability. So this is a wonderful indicator of an unstable spine, and you do stabilization and you cure the person. This is an unstable atlantoaxial joint. So here there is a manifestation. Bifid is a manifestation. But there can be, now you see this thing. There is no compression at the craniovertebral junction. There is some deformity in the spine. And there are remarkable clinical symptoms of high cervical and low cervical myelopathy. This I call central or axial atlantoaxial instability, and believe me or not, there are several patients who come with symptoms of giddiness, vertigo, pain here, pain there, inability to sleep, pain in the neck, difficulty in walking, difficulty in lifting. There are hundreds of non-specific symptoms. And believe me or not, you have the power in your hand to cure these patients if you have the understanding of the issue of central or axial atlantoaxial instability. So this is one recent patient I did during the COVID times. You see, this is in the hospital. The hand was not going up, and in the hospital, the hand has started going up. And you see the shoulder is drooping, and even the dressing has not been removed. The shoulder has come back to normal. So this issue is of central or axial atlantoaxial instability is an absolutely dynamic understanding of the subject. Of course, there is a possibility of going wrong. Of course, there is a possibility of doing unnecessary operation, but that is in your hand and that is in your mind, whether you want to understand this issue properly or not. Hirayama disease, nobody in the world knows what is the treatment of Hirayama disease. Nobody in the world. So this was my article some years ago, where we said that this fat introduction in the spinal column is a protective natural maneuvering in the presence of multi-level spinal instability, and stabilization is the treatment. Now we have got several cases of this rare problem of Hirayama disease where we have treated by multi-segment stabilization, including atlantoaxial joint. So now I want to introduce another concept. Can foramen magnum decompression surgery become historical? I am saying, of course, it is a statement which is quite a, many people are doing all over the world foramen magnum decompression. But I am saying that there is a beautiful occasion for you to realize this new concept and try to see this field in a new perspective. So we now go to another fantastic new concept about movement. And I want to take you to the whole world of degenerative spine. And I want you all to listen to these fantastic new concepts in a right perspective and very carefully. Of course, I will be answering your questions at the end of my lecture, but carefully listen to these concepts. You see, the whole human spine, spinal muscles are located in the back of the spine here, back. And very few muscles are related to the disc. You must read this beautiful article of mine where we said that disc is divine, disc is God, disc can never go wrong. Disc is like air in your car tire. If there is no air, the car cannot run. But what the car needs to run is petrol or that fuel is provided by the muscles. So muscle is the source of energy and muscle is the point of movement that we know. And all the muscles are acting on the large facetal articulations. And if the muscles go weak, the facets will be affected first, and facetal instability will be manifested first. Disc changes are not primary. Now, please carefully listen to me. What I'm saying is that disc space reduction, disc degeneration, osteophyte formation, ligamentum flavum buckling, which are all considered in the entire literature on spine as pathological entities, are not primary issues. So we wrote this article on degeneration of craniovertebral junction. There was not a single article on this subject earlier. We wrote that more the movement, atlantoaxial joint is the most mobile joint, more the movements, more the muscles required to conduct those movements, and more the possibility of instability or degeneration of this junction. So craniovertebral junction instability and degeneration is a very common. It is not understood and it is not treated clinical entity. So now you carefully see this slide where I have shown that reduction in the joint space, buckling of the posterior longitudinal ligament, osteophyte formation are not primary clinical entities. I am saying that this compression is not primary. It is an indicator of an unstable atlantoaxial joint, buckling of ligamentum flavum, which everybody in the world terms as hypertrophy and pathological hypertrophy, osteophyte formation as pathological entities, reduction in the joint space as pathological phenomena, and age-related degeneration. I am saying that it is not the primary problem. Primary issue is the muscle weakness, disuse, abuse, misuse, or injury of the muscles results in an unstable joint, and these are all secondary and protective measures, not harmful, but protective. Bone formation in the apical ligament is an indicator of an unstable craniovertebral junction. Compression is not the issue, and decompression is not the treatment. Craniovertebral junction stabilization is the treatment. These bone formation are natural protective maneuvering. They do not need direct surgical intervention. They do not need removal. So my concept is absolutely clear that these osteophyte formation are indicators of an unstable spine and indicators of the need for atlantoaxial stabilization. Another entity which many of you know, that retroodontoid bony formation or pseudotumor formation, I call it an osteophyte of craniovertebral junction. The whole world was treating this by removal, by decompression of the odontoid and removal of this tissue, which we said for the first time in the literature that this indicates unstable craniovertebral junction, and this does not need decompression from front or decompression from behind. This needs stabilization. So this has completely revolutionized this subject. Many of you know, and many of you treat with this philosophy. And in the year 2004, we talked about this for the first time in the literature, and the treatment for this entity has completely changed without any question. Now you see this retroodontoid cyst formation. We said that you do atlantoaxial stabilization, this cyst can disappear in the immediate postoperative period. Removal of cyst is a very easy surgical procedure. You puncture the cyst, the thing is gone. But this is not primary. There is no need for decompression. The need is atlantoaxial stabilization, and it can disappear immediate postop. When there is a retroodontoid or retro C2 body cyst, there is a presence of unstable craniovertebral junction, even when it is not shown by radiology. Even when there is no radiological or bone abnormality, it can be a centrally unstable craniovertebral junction, and it needs atlantoaxial stabilization. Rheumatoid arthritis, many of you know, that the whole field of craniovertebral junction was focused on removal of this spinous. You come transorally and remove this spinous was the treatment. Many people did posterior decompression, but in 1980s, anterior compression means anterior decompression. So now I am saying that this spinous is not a primary issue. It is an indicator of an unstable atlantoaxial joint, and it indicates the need for atlantoaxial stabilization, no need for decompression. So what I am saying is compression is never a primary issue. Decompression is never a primary treatment. So we wrote about this issue of pannus, issue of cyst, issue of retroodontoid tumor on several articles on this subject. And many of you know that we introduced this intra-articular spacers. I don't use it too often, but these are meant to stabilize the spine. They are not meant for realignment of spine. Essentially, what we need is stabilization of an unstable spine. That is the treatment. So this is my joint jamming technique. Now I want to go to an absolutely dynamic phenomena, a dynamic anatomical substrate, which unfortunately has never been capitalized in the subject of spine. These are the facets. You see the huge facets. If you realize the facets are bigger than the vertebral body in the vertical extension, that is one. If you hold the bone, the facets are the strongest point of the whole vertebra. They are thickest and the strongest. Vertebral body is quite a callous, or it is not a strong bone at all. The pedicles are strong, but they are not strong like facets. And this oblique orientation or oblique profile is the genesis of listhesis of the facets, a subject which has never been discussed in the literature. We have talked in 1999 about listhesis of C1 over C2. Now I want to introduce to you listhesis of the facets as the prime problem in cervical and lumbar spinal degeneration. So what I'm saying is reduction in the joint space, reduction in the disc space height, bulges of the disc, osteophyte formation, these disc bulges, and the compression that you are seeing in the cord or in the dural spine or the lumbar spine, they are not primary issues. They are not primary problems. They are indicators of an unstable spine, and they are indicators of the need for stabilization. My concept is absolutely clear and without any confusion that compression is not the problem. Spinal stabilization is the solution and is the issue. You don't do decompression by removal of this disc or removal of this lamina. Don't do corpectomy, corpectomy, corpectomy. Don't do laminoplasty, laminoplasty, laminoplasty. It does not need that treatment because it is an unstable spine, and vertical facetal instability is the point of genesis of the problem. So in the year 2006 or 7 or 8, we introduced this concept. I have changed. Subsequently, I have changed. So this is my preliminary concept. You carefully listen to this concept, that there is an osteophyte. The whole world will remove this osteophyte. And you agreed with that. Remove the disc and remove the osteophyte. But you distract the facet, the disc will, this compression will disappear. This osteophyte has the potential to disappear. This ligamentum flavum buckling will disappear. More importantly, the patient will remarkably improve in the clinical symptoms. Now you see this slide, there is buckling of the disc space. There is buckling of the, this is not hypertrophic. These are not pathological. They are not abnormal. They are natural. They are natural protective. I am saying that they do not, they look like causing compression, but they are not the problem. Problem is unstable spine. You distract the facet, the ligamentum flavum will debulk, the osteophytes will debulk, and the whole cord will come back to normal. There is no need to remove the osteophyte. There is no need to remove the bone. There is no need to do any kind of decompression. You see this, there is a compression here. There is facetal distraction, and there is a new disc formation. The buckling is gone, and the patient has remarkably recovered. This is another case. You see the new disc formation, and multi-level facetal distraction can be done in multi-level spinal instability, which is more common than single-level elderly patients. There will be no one level or two level. There will be multi-level compression, multi-level instability. So I have removed this word compression from my pathological list, decompression from my treatment list, and stabilization has been introduced. So there is multi-level spinal instability. There is multi-level spinal stabilization by distraction. So my treatment is instability is the problem, stabilization is the treatment, decompression is not primary, compression is not primary, and decompression is not the treatment. So multi-level spinal issues you treat by multi-level spinal stabilization, and you see in the long run, the entire compressive phenomena is disappeared. There is no decompression at all. There is no anterior decompression or multi-level corpectomy, which are not easy procedures. You know, multi-level corpectomy, multi-level discoidectomies are not easy. They are dangerous and difficult. You do this distraction fixation, remarkable, easy surgical procedure. I will not say easy, but quite easy. You see, this is another case where this is the compression and this is the treatment by facetal distraction. I am already telling you that this is my earlier thought process. I have changed, and what changed I will talk to you very soon. So you can do multi-level facetal distraction and fixation. So this is multi-level facetal distraction and arthrodesis. So you see here, there is multi-level. Don't do discoidectomy, don't do osteophytectomy, don't do corpectomy, don't do laminectomy, don't do. This is my an absolutely don't do. And you see there is complete reformation and movement restriction due to multi-level spinal stabilization will be the outcome. You see multi-level spinal arthrodesis, multi-level facetal distraction, and I just want to rapidly show you a video of this technique. So this is the midline here, and this is the facet which I am opening. And this is, I call it Goel facet spacer. This is my patented facet spacer. Even the C1, C2 facet spacer are my patent. So what I have done in exactly 20 seconds, I have stabilized this spine and I have completely immobilized and distracted this spine. Now you see the other one. This is completely unedited version. Completely unedited. More important is because I have distracted this, this one has also, the space has become reduced. So I am finding a little bit difficulty in introducing this spacer. So this is my earlier surgical strategy. I have changed, which I will talk to you very soon. So I used to introduce these spacers, and now you know this, many people in the world are doing. So I am now going ahead in this. This is on the other side. There are multiple spacers that have been introduced. As you can see, There are multiple spacers that have been introduced and stable spine. Now this is the preoperative. You see the osteophyte, this has completely disappeared. And you see this stabilization, and this patient is talking. I'm not sure if you can understand, but let me, he's talking in Marathi. He says that he's completely relieved of his symptoms. I know you will not understand, but he's saying that everything is gone, no symptom. He says he could not move his hand and legs and all those things, and now he's completely relieved of all his symptoms. So, okay, so because you cannot understand, I know. Now you see here multi-level spinal compression. Don't use this word compression. You can use this word multi-level divine introduction of these in osteophytes, and you see there's a, this is distraction and this new disc formation. The osteophytes are gone. This is immediate postoperative period situation. And here also there is a video, but I will. Now he's walking and all. He used to be, he came on a wheelchair, and now he's coming on his own, in a taxi. He can, now he's walking with support. So this is, he's talking in Hindi, so I'm sorry you cannot understand. But the concept of intrafacetal spacer was a concept. The concept was that there is no need for decompression. The concept was instability is the issue. So from here, my life in spine surgery changed. So this was the article which was published as a cover page of Journal of Neurosurgery 10 years ago, where facetal distraction was suggested as a modality of treatment. And now this article is very heavily cited in the literature. So this introduced a new concept. This article is a concept which says that spinal degeneration does not arise in the disc. If you read all the articles for last 100 years on spinal degeneration, it is mentioned that the water in the disc space reduces due to age, disc degenerates due to age, and that is the cause of the problem. What the hypothesis we have changed is completely different. We have said that disc is divine. Disc is not the problem. The problem is you, because you have not exercised your muscles. You have not used your muscles. You have either injured your muscles or you have not exercised, and that is the problem, and that leads to an unstable spine, and that is the problem. So we have studied the facets by various articles on this subject, and we introduced these facet spacers as a form of treatment. And this is very heavily patented in India and in US, and there are more than 25 patents of mine on this subject. So that is my historical perspective. I will little bit talk on this spacers more. Like you see here, this is the disc herniation. Posterior longitudinal ligament is intact in this situation. So I did distraction and the disc disappeared, went back into its house. So this was the article, immediate postoperative reversal of disc herniation following facetal distraction surgery. This article I wrote about 10 years ago. This is another osteophyte or disc kind of compression. After about 8 months of surgery, you see the whole thing has disappeared, and this is the stabilization. This is another case of this type of herniation and osteophyte. The posterior longitudinal ligament is intact. You see the whole system has come back to normal, and there is no discoidectomy, no laminectomy, no nothing. So similar concept we introduced in the lumbar spine, like lumbar canal stenosis or lumbar multi-level compression, which is a very commonly used term, I am saying that this kind of disc bulges in the lumbar spine are not primary processes. They are indicators of multi-level spinal instability due to your muscle weakness, and what you need is stabilization of your facets. So we introduced this concept in the year 2013. I have done this several years ago. So introduced for lumbar canal stenosis, multi-segmental facial distraction stabilizers, no decompression of any kind. So that forms the treatment of lumbar canal stenosis. So we also studied lumbar facetal anatomy and lumbar facetal morphometry. My various colleagues have done this study. Just read this beautiful slide. Is the symptom of cervical or lumbar radiculopathy and evidence of spinal instability? Say there is no osteophyte. But the person is having pain in the shoulder, pain in the hands. What is the problem? Means if osteophyte is not there, you will not treat. That is the main thing that we are taught. If there is osteophyte, go and remove the osteophyte. If there is no osteophyte and there are symptoms, then what? It can also indicate the presence of an unstable spinal segment, and it can indicate the need for stabilization, even if the radiology is normal. So, like central atlantoaxial instability in the craniovertebral junction, there can be multi-segmental spinal instability in the cervical and lumbar spine. There can be symptoms related to it, and it can indicate the need for surgery. So there can be clinical indicators and there can be radiological indicators of an unstable spinal segment. So this concept that decompression of the compressed and deformed neural structures has been the basis of surgical treatment for several decades. All of you agree, and all of you are many of you are doing this. Decompression for compressed neural structures, like compression caused by osteophyte, compression caused by ligamentum flavum, compression caused by disc bulges. What we do is we do decompression. Now I take you to another field, another generation of my understanding. I was doing distraction to do secondary decompression, but now my concept is the problem is instability and the treatment is stabilization, only fixation as the treatment. In 2013, I introduced this concept, and recently I published my experience with 215 cases of heavily disabled patients with cervical degeneration. Only fixation, no decompression, no discoidectomy, no osteophyte removal, no laminectomy, no ligamentum flavum removal. You see, there is multi-level problem here. Osteophytes are here. So what this indicates is you come and remove the osteophyte, you remove the disc 2 level and do cages, and all those things are very well known in the field. But what I have done is I have done only stabilization, identification of unstable segments. You see, there is no compression here, but I have done the fixation here. So even when there is no compression, there can be instability of that segment. So this is a very important new thing that is there. So these are indicators of unstable spine, all right. But there can be unstable spine above it, and there can be unstable spine below it that you have to identify. And you see this patient. This is the patient after surgery. Unfortunately, she is talking in Hindi. She was saying that she was having numbness. So now she's walking quite stable. She was hardly able to walk before operation. And this recovery is in after 1 or 2 months of surgery. So you see this two-level compression. Compression is a divine thing. You don't remove this compression. Don't worry about this decompression. And you know, if I say this, the whole spine surgeons will start shaking if I say, don't worry about this. But I am saying, don't shake. Come and do this very small and simple operation, and it will be not even 20-minute operation. Stabilize this. I have cut the spinous process. This is no decompression. And this spinous process I have used for bone fusion. And you see this compression is gone, and the patient has remarkably improved in the clinical symptoms. I will show you several of these patients. Now you see this patient having multi-level compression, and he had come not on a wheelchair. He had come on a stretcher. He was not able to even stand or move. And now I have done this stabilization, multi-level stabilization, and you see this patient. If you can hear and understand what he says, I will be happy. He is walking. He came on a stretcher. Okay. He was not able to do anything. And he will say this in my language, in my mother language. And you please try to decipher that language from his smile. He says that his family had taken him as a dead man, and he was taken on a stretcher as a dead man, and now he's able to move. So he's thanking the doctor. And you see the compression is completely finished. And there is arthrodesis, and there is no decompression. This is another case. You see there is a bad compression here. And this patient, let me see if.
Now, Sangha.
You see now you can see this person walking and this person walking and this smile. You see this person walking and this person walking. They are giving a lecture in my language, but you can see the language of smile and the language of teeth and laughter, and that is what matters in our life. You see this multi-level degeneration. The whole world will do laminoplasty. Many people will do corpectomy and discoidectomy and osteophytectomy. But you see this alternative form of treatment, a revolution in the treatment, revolution. And you see here, completely the osteophytes are gone, the ligamentum flavum bulges are gone. There's multi-level spinal stabilization and an absolutely new life to the person. So this degenerative cervical myelopathy, I had written an editorial in the journal Neurospine. So what is important is to identify the indicators of spinal instability on the basis of clinical symptoms and on the basis of radiological indicators. And then you do spinal stabilization. And I also have introduced, you see, when you are seeing an osteophyte at C4-5 level, during operation, you assess the C4-5 level also. You assess C3-4 by manual manipulation of spinous processes. And you can easily identify the unstable spinal segments and stabilize. So you see this two-level issue, and this is completely gone. And this patient has needed 4-level stabilization. And that is a very crucial issue, which levels to stabilize. So this is another case of multi-level stabilization, and you see completely normal cord, no evidence of any kind of compression of the neural structures. There is complete arthrodesis of the treated spinal segments. This is another one treated by only fixation. This is another one treated by only fixation. You see this osteophyte has disappeared. This is another multi-segmental issue which the spinal surgeons will like to do laminectomy, and we have been taught about that. And some people, because anterior compression has been considered to be an issue, some people will do anterior decompression. So I am saying the compression is not the problem, decompression is not the treatment. Instability, which is manifested at the facets, is the problem, and facetal stabilization is the treatment. This secondary so-called pathological, the whole world is calling osteophyte pathological. Ligamentum flavum, they find some kind of mitosis in that. Osteophyte, they find some kind of calcinosis in that, some kind of familial, some kind of genetic. This is nothing genetic, this is nothing familial, this is nothing problem. The problem is your unstable spine, and the treatment is not genetic. Do not attack the natural processes, do stabilization. So I will quickly show you the technique of stabilization, and many occasions I do this stabilization 5 level or 4 level in half an hour. You see that unstable. You see the unstable facet. This is the midline, and this is the facetal instability. And you can see the facets are completely unstable. This is I don't have to know, my assistant and my colleagues are doing this kind of exposure in. And when they do, I just come and take the machine in my hand and start drilling. And within 15 minutes, I have done 4-level fixation or 3-level fixation. And that is the treatment. And that treatment is, I have to tell you, my dear friends, that treatment is no ordinary treatment. That treatment is magic. That treatment, I have told many of my friends who are doing this, that if you want to see magic, do this. How to introduce this screw and how to stabilize, you have to learn. Once you have introduced the screw, it becomes absolutely stable and it becomes like a rock. You have to go in an oblique direction. I do Camille's technique of fixation, and you can identify the osteophytes. You see the osteophyte in the vicinity of the facet. This is the joint. You see you go oblique this is the spinous process. You do this fixation. Now I avoid using spacers, but spacer is another wonderful tool which I use on some occasions. And you see how quickly you can do. Imagine you are doing corpectomy and fixation. You will take hours in drilling, dangers in drilling. You can kill the recurrent laryngeal nerve. Dangers to the esophagus have been suggested and shown and experienced by many. You do this fixation in 15 minutes and you can do the next operation on the other table. So sometimes I do 6 or 7 cases in one day. And this smoke is of course not good, but you have to do continuous irrigation and then you do this fixation. You see this screw implantation and you do then, of course, you have to, this was real time. There was no editing here. But then after the screw, multiple screws that you are seeing, you drill the posterior surface. I use the spinous processes as bone graft. When I use more than two levels, I use iliac crest bone graft. So what you are seeing is there is no decompression. There is an attempt of fusion, arthrodesis, no decompression, no laminectomy, nothing, no laminoplasty. So this is the multi-level issue. And you see this is the stabilization. And you see this in the long run, this will disappear, this compression will disappear. This is another case. You see the whole cord is released and there is multi-segmental stabilization, no decompression. So essentially, instability is the cause of symptoms. Compression is not the cause of symptoms. Compression is an indicator of instability and stabilization is the treatment. So that is for degenerative spine. It is not neural deformation or compression, but instability is the cause of symptoms. What we have to do is we have to understand and analyze and identify on the basis of clinical and radiological parameters, the indicators of spinal instability. And there are very well-defined indicators and they need to be stabilized. I now take you to another absolutely magical concept: central atlantoaxial instability in cases with multi-level cervical degeneration. Now you see here, there is multi-level cervical degeneration. There is no compression here. But you see, there is an unstable atlantoaxial facetal articulation. You need to stabilize atlantoaxial joint if you want to treat this patient. Otherwise, you are not treating your patient. And then you need multi-level spinal stabilization. So atlantoaxial joint stabilization is a very important new introduction in multi-level spinal degeneration. When you talk of spinal degeneration, you talk of C5-6, C6-7, C4-5. Never you talk of C1-C2, but C1-C2 is a very common unstable spine in cases with multi-level spinal degeneration. So this is the case. Now let us see what this person is saying. You just see the smile. I think he should show you the smile. He says he's 99% better. And imagine if I am saying stabilization can return him to 99%, my concept is decompression can only worsen him in the long run, maybe in the acute. So in cervical spondylosis, when the person comes on a wheelchair, when the person is not able to walk, when the person comes on a stretcher, at that time, atlantoaxial stabilization is mandatory. You see this patient, there is not much problem here, but the facets are unstable. There is no compression. So there is a need for multi-segmental stabilization, including atlantoaxial joint fixation. And you must read this article. I have to say that you can create magic in the life of these people. Magic. You have to believe me. If you do not believe, you can read these articles. If you cannot read these articles, you please come and spend some time in my department. Even senior people like Vladimir Benis wanted to come, but this corona has a little bit disturbed his tour, but he will come sooner than later. I want Yoon Ha also to come. So you see, atlantoaxial joint, we introduced a new technique of fixation of C1, C2, 3 joint. You must read this article because there are many fantastic things in that article. You see, there is you may not do direct C1, C2 fixation, but by doing C2, 3 fixation and cutting the C2 muscles, you can do atlantoaxial stabilization. You read that article and you will get details about what I want to say. Now you see this patient who has undergone this treatment, and you see the way she is walking and the way she's walking here. You have introduced a magic in her life. You have given her a new life and you have given her new vision. You see, I'm running both the tapes together. So I will stop this. See the smile on her face. See the satisfaction on the face. Now, this is another patient. You see, there is a fixation, only fixation. There is no decompression of any kind, multi-segmental. And you please see this patient.
नाम बताइए अपना जोर से बोलो नहीं सुना दिया जोर से बोलो हाँ दोनों हाथ ऊपर उठाओ उठाओ जितना उठा सकता है उठाओ ऊपर पूरा उठाओ पूरा नीचे करो दोनों हाथ का मुट्ठी खोलो बंद करो
So this guy is, you know, he was not able to walk properly. Now he's smiling. And you see, he can do various things he would not have imagined. You see this multi-segmental? Don't do osteoid removal. Don't do corpectomy. Don't do laminectomy. Just identify the facet. Do a half-hour operation. do multi-segmental fixation, and you see the outcome. See, unfortunately, he's talking in my language. You see, I would have loved if you had, now he's able to walk. He was not able to walk before operation. So what we have done is, you see this multi-level osteophyte, ligamentum flavum hypertrophy, natural protective maneuvering. You see this post-operative, the cord is completely, and you have done multi-level fixation. You can introduce double insurance screws, like 2 screws at one level. So I call it double insurance. So this is a modification of Camille's technique. So this is multi-level, and I have done multi-level stabilization. Now I have several hundred patients. Sorry, this is going back a little bit. Now, yeah. Now this patient has undergone fusion of C3, 4, 5 level, and he has come with remarkably bad worsening symptoms. So now you see this adjacent segment central instability when there is a fusion done at the C3, 4 level. So you have done fusion and the patient has worsened. Now what you will do? You will say, I can do nothing. There is no compression. I can do nothing. What you will do here? Nothing. But there is a central instability. You do atlantoaxial stabilization and you see the wonder, you see the magic. Let me see if I have, you see here, this is another patient where there is multi-level fixation done and he has come with worsening issues. Now you see, see, he's come on a wheelchair. He's hardly able to move his hands. He's hardly able to move his neck. Now he has come standing at follow-up. You see, he has come on a follow-up when he has come for stitch removal. And he has come standing and walking without compression. So I will stop this. But you see, there was no compression. And what I have done is fixation. And I have given a new life. So you can give an absolutely brand new life if this concept of central instability is clear in your mind. Lumbar canal stenosis. You see, this article was published in Neurosurgical Focus. You read the title. Analyzing the role of stabilization and the futility of decompression. So whatever statements I'm making, whatever sentences I'm saying, all these things are published in very reputed journals, as you are seeing. So this multi-level spinal stenosis, these bulges are natural protective maneuvering. There is compression, but this compression is not the problem. The unstable spine is the problem, and this patient needs stabilization, no decompression, and you will see a magic. You will see a magic in the immediate post-operative period without any doubt. And you want to witness this magic, you do it. If you want to argue with me, no, I want to do decompression. There are some people in my own city who have now started doing decompression plus fixation. I am saying you have gone one step ahead. Why don't you go another step ahead? Don't do decompression. Suppose this fixation only fails, you can come back and do decompression at any time. What is the problem? But I am saying you will never need decompression. And that is the beauty of this. You see, this disc space reduction, osteophyte formation, deformities are not primary processes. They are not compressive elements. They are indicators of an unstable lumbar spine, and it merits multi-level stabilization. And the best form of stabilization is fascial stabilization. Some people say, I will do pedicle fixation. You can do pedicle. Of course, you can do pedicle fixation if you want to do more difficult technique. Some people say, I will come from lateral, from the transoral, and I will do anterior fixation. You can do this hopelessly dangerous procedure from anterior, or you can come from abdomen, you can do all these kind of procedures. But why don't you use the strongest elements of the spine, which are the facet, and you do in 5 minutes this fixation, and you will see the wonders of your surgery. This does not need decompression. This needs stabilization. So let me show you this, what this gentleman is saying. You try to understand from his.
ऑपरेशन से पहले मेरे दोनों पैरों में से लेके कमर तक दोनों पैरों में बेहद बहुत ज्यादा दर्द हुआ करता था, लेकिन ऑपरेशन के बाद से आज तक 10 महीने हो गए, बिल्कुल जरा सा भी वो दर्द नहीं है.
He's saying that there is no problem in his legs after surgery for 10 months and he's feeling happy. So these kind of, I do not call it spinal canal stenosis. I call it multi-level spinal instability. And I introduce 2 screws at each level. I call it double insurance screws. And you see this multi-level fixation now. I have got several hundred patients of this kind of treatment, and I have never repeated the operation. Sometimes I introduce 3 screws at each level. You see, there is the facets are so big and so strong, you can do triple insurance fixation, which is a big possibility and a wonderful possibility. And so this lumbar fixation for lumbar canal stenosis, I consider an absolute misnomer. Don't use that word stenosis, because if there is stenosis, you need to do decompression. This is a misnomer and it indicates a wrong kind of treatment. That is not a good form of treatment. Now you know about this entity of lumbar scoliosis. You see this lumbar scoliosis, de novo lumbar scoliosis. I have treated very high profile people with this, including a president of one country. I treated this. You see this scoliosis is there. Now many people in the world will do decompression and kyphectomy and all this kind of bone removal. But what I have to say is all these are protective manifestations of unstable spine. You do fixation and you do relief of the patient. You see this patient is here, old people, and don't need to do any decompression. You need to do fixation and stabilization. They are manifestations of unstable spine. Beautiful article. You must read this article. Do you need to resect osteophyte? Now, many people will say osteophyte removal is the bottom line or the baseline of spine surgery. The whole spine surgery is based on removal of the osteophyte or by doing laminectomy to give space to this osteophyte. I am saying that it is not necessary to bother about this osteophyte. You do stabilization and this osteophyte will disappear. So this was my recent article, outcome of osteophytes after only fixation. Now you see this beautiful. So this degenerative spinal canal stenosis is an absolutely misnomer. Sorry, I think I have gone in the wrong direction. My osteophytes will come later where I am showing the osteophytes disappearing. Unfortunately, okay, I will show you later. This kyphosis, you see this kyphosis, cervical kyphosis? I am saying this kyphosis is a manifestation of an unstable spine and you need to do stabilization. You don't need to do decompression. You don't remove this kyphectomy and all those things are not good procedures. If there is unstable atlantoaxial joint, you just do stabilization. If there is no atlantoaxial instability, sorry for that. Sorry, I am just coming. There is some issue here. John?
Yeah, you can't screen share?
Yeah, I'm trying. Yeah, I'm back.
There you go.
Okay. There was no problem up till now, right, John?
No.
Okay. So this kyphectomy is the described procedure. Decompression is the described procedure. What we said is, when there is atlantoaxial instability, you need to do only atlantoaxial fixation. Otherwise, you identify this C of this hump and the limbs of both the C, the entire segment has to be stabilized. So you must read this article of mine where we have mentioned how to treat these patients and what not to do is to remove this bone. What not to do is to do decompression either from front or behind, because that will be an absolutely negative surgical procedure. So this is the kyphus kind of thing, and you have done fixation. This is another kyphotic spine. Now, when I do subaxial fixation, when I include C1, C2, are issues which are well described in my article, and I wish you can read those articles. Now, another absolutely fantastic thing I am going to talk to you, and which you may find absolutely unnerving. What do you do about prolapsed disc? The whole world will go and remove that disc, right? I am saying that prolapse of the disc is a manifestation of an unstable spinal segment. Either prolapse is a manifestation of unstable spine, or unstable spine results in prolapse of the intervertebral disc. So prolapse of intervertebral disc is an indicator of an unstable spine, and only fixation is the treatment. Don't need to touch the disc. So this is an absolute revolution. So there is a disc herniation here. There is no question in my mind. The whole world will come and remove the disc. This disc, you will say there is root canals, this and that. But you do this fixation, identify the unstable segment, and you see the magic. Why don't you try and see the magic? And this will disappear after 6 or 8 months of surgery. There is no disc left, and this patient is completely cured, and there is no discoidectomy, there is no laminectomy, there is no microdiscectomy or a huge discectomy. There is no lateral surgery, or there is no anterior surgery, there is no endoscopic surgery, there is only fixation. So I wrote this article, which is on several patients where I have done only fixation for cervical radiculopathy, no discoidectomy. Same concept I use for lumbar disc. You will say that I can remove the disc in 5 minutes and 10 minutes. I can also remove the disc in 5 minutes and 10 minutes. But I am saying, if you do only fixation, this disc will resolve in 6 months, and the patient will be cured. A magic will be seen in the immediate postoperative period that you have not seen with discoidectomy. So now I have got several patients which I published, and you see the disc disappearing, disc finishing, and the patient recovering remarkably in the immediate postoperative period. This is after 6 months of surgery and stabilization. You see the disc is at this level. In some cases, the upper level is also unstable. Then we say that upper level I have not done. Then there was adjacent segment disease and all those things. It is not adjacent segment disease. It is because you have not identified the unstable segment, and you have not treated the unstable segment at that time. So identification of unstable segment and stabilization is the treatment. So this is another case of disc which has resolved after surgery. And I have got, as you can imagine, several patients, and this is after a few weeks of surgery, only stabilization of the spine as the treatment of prolapsed herniated disc. And recently I reported my experience with 44 cases of lumbar radiculopathy disc with 100% clinical outcome. Now there are two things that you will have in mind. One is that I don't want to do this because disc is I am doing for last 20 years and I am very happy with my outcome. That is one thing you will say. Second thing is you will say, I don't believe in this. But third thing, you have to imagine and remember that you want to create a magic and you want to create a long-term magic. Try this. Suppose your fixation fails, you can next day come and start doing the removal of the disc. But I am telling you, you will never have that opportunity. Another beautiful thing, you see, lumbar canal stenosis, pain and symptoms characteristics. Sometimes you can have an unstable cervical spine. This patient with multi-level lumbar canal stenosis symptoms, also having multi-level cervical symptom with some problem in the hand. I treated the hand stabilization. The lumbar canal symptoms completely disappeared, at least now for 2 years, more than 2 years. At least I have treated some few patients here, 12 cases are treated here, and nobody has ever come for lumbar canal surgery. Now I want to take you to another dimension of spine surgery, another absolute revolution in spine surgery. And those who are treating OPLL will know what problem OPLL surgery can cause. I am saying that OPLL and cervical spondylosis are same. I am saying that ossification is a manifestation of an unstable spine. Cervical spondylosis is unstable spine. OPLL is unstable spine, and you need only fixation. Atlantoaxial instability is very commonly associated with OPLL, and you have to treat atlantoaxial stabilization also has to be done. So now this OPLL, don't do decompression, don't do laminoplasty, don't do corpectomy. Just come from behind, do this fascicle fixation in 15 minutes and see the magic and enjoy the magic. And your patient will relish that magic for his lifetime. Only stabilization, the ideal treatment? I'm saying absolutely. This article I published about 7-8 years ago. And now I have got several patients with OPLL treated with only fascicle fixation, about half an hour operation. You do corpectomy 3-level or 4-level, and you see the number of hours you spend and the type of danger you encounter. So recently I published my experience with 52 cases of only fixation for myelopathy related to OPLL. So this is high cervical OPLL. You see, I have done multi-level fixation, including atlantoaxial joint, and magic is there for you. Multi-level segmental OPLL. Don't do corpectomies. Don't remove this osteophyte and OPLL. Don't do laminoplasty. Just do fixation in half an hour and see the magic. And that magic you can never imagine. You see this OPLL, just do fixation like this. Atlantoaxial fixation is necessary in these cases. And let us see what this person says. See the smile. This smile you can never see in OPLL patients. They are demolished. OPLL patients are see the smile and see the smile. I am not able to explain you her smile, but I can explain to you her language. She says that there was one bullock who ran after her and about to hit her, but she ran so fast and she could avoid the bullock and she's bull. And she says that if I was there, I would have been very happy to see her running. And you see the smile, and she has got a new life. So what I'm saying is, don't do decompression. Don't do decompression. Enjoy the magic of 15-minute surgery rather than doing 15-hour surgery on this kind of corpectomies and other kinds of things. So this is another case of OPLL. You see, I have done fixation. Let us see what I... See, this patient was quite demolished. You can see. You can see the patient hardly moving his limbs. You see, very, very demolished patient. And now you see he's sitting. And you see, this is in the immediate post-operative period. You see, this is in the immediate, he has come. He's still quite weak, I can say. See, he's moving his hand. You see, he was hardly able to move his hand. You see his hand? You see his legs? He was hardly able to move. Now he's able to stand with support. So what I'm saying is, don't do decompression. Do fixation. Suppose you don't agree with me. Okay, I will agree that you don't agree with me, because it is natural that suddenly you say that, but you have already done fixation. So when you do decompression, you don't need to do fixation. So try this. Try this magic and see this delivery of a new human being. So Camilla's technique is, I like this technique. I use double insurance technique, and this is definitely an underused surgical procedure. You can introduce 2 screws, you can introduce 3 screws, and you can do a solid fixation. So for OPLL, I am now saying that atlantoaxial and subaxial cervical fixation can revolutionize the treatment of cervical myelopathy related to OPLL. Absolute revolution. So the thing is, can decompressive laminectomy for degenerative spine for spinal stenosis become historical? Absolutely, it will become, like transoral surgery has become historical, like foramen magnum decompression surgery will become historical. Decompressive laminectomy, corpectomy, discoidectomy can all become historical operation. Is instability the nodal point of pathogenesis of both cervical spondylosis and OPLL? I am saying absolutely. So what is the discussion is, like anterior transoral surgery, will anterior cervical spine surgery find space in the history books? Anterior surgery, retraction of the trachea, retraction of the esophagus, retraction of the laryngeal nerve, retraction of the muscles. Can they become completely historical? I am saying yes. Can this operation of laminectomy, can this operation of corpectomy, can this operation of laminoplasty, can this operation all become historical? I am saying yes. And this is my revolution. So what the journey is, from only decompression was the treatment not long ago, and even now, a century-long treatment is now only fixation is the treatment, no decompression. So atlantoaxial and subaxial spinal fixation can, of course, change the treatment. So my revolution is, and my revolution is fixed in my mind and extensively written in the literature. This is not a idea that I have got. This is idea which I have got and which has been executed and which has been published. And there are several neurosurgeons in the world who have now started thinking about it, if not doing about it. The concept is compression is never primary. Compression is always secondary, and compression is always protective and a natural protective maneuver. Decompression is never the treatment, no decompression. So this is one nice New Year card that I received from one of my recent patients. And she says, shine bright. So she changed into spine bright and said thank you to me because she got a new life following only fixation for her central or axial, atlantoaxial instability. Thank you very much, my dear friends. So, my dear Dr. Professor Ha, I want you to say, I know it is a little bit too much, but I want you to comment on what, and then I will like Vladimir to comment, Dr. Oscar to comment, and I know that there are several questions. You know, can you believe there are more than 100 questions on the chat box? But I
Oh,
want
how's the tool? Yeah, just look over the questions, see which one you think are appropriate.
Okay, first let me see what Professor Ha is saying about this presentation. John.
Sure.
Yeah, can you hear me?
Yes, yes.
Okay, so it's really exciting, and I learned a lot from your lectures. I really enjoy your paper. So, but it's not easy to adopt myself because we have a kind of a traditional concept that the surgical treatment of spinal disease is mostly decompression and stabilization. But today you comment, your concept shows the decompression is no longer necessary. So stabilization is the only key. I agree with you. I also have some experience that when we do fixation alone. It just in case of the patient with many comorbidities or something like that. So, but in that case, I have a same experience like you mentioned. Patient has getting better without decompression, without decompressive surgery. So, but you extend your scope to the general spine surgery practice. This is amazing, and I think the revolutionizing idea and concept. But I have just only one question. How's your perspectives of the motion preservation surgery? There's a big trend in the spine world. There's a motion preservation and the stabilization. There's a kind
Yeah,
of
I know.
wave. Yeah.
Yes.
So
Yes, Professor Ha, I can understand motion preservation is a big issue. Introduction of artificial disc and all those things are big issues in the spine surgery. But my feeling is, you see, if you read one of my beautiful articles on disc, I have written that disc is divine. Disc is made by God, and no human being can ever replace something like what God has made for us. I have even designed artificial atlantoaxial joint disc. I have designed my own self. It is my patent. But I don't think that we can ever replace the natural powers of disc. But my concept is that disc degeneration, disc herniation are all related to an unstable spine. And when it happens, you stabilize that, and the adjacent segments will then take over. The other question that Mehmet Zeleli has been asking me, and he has put on the chat box also, that we are very happy with decompression and fixation as the treatment. Now, I have to tell you that the whole world is happy with decompression for last 100 years. But we have to think, if there are something which can be changed, we have to think about it and try to see if we can change. I am not saying whatever concept I am giving you are absolute final and you have to follow, otherwise, it is not good. You think about it. My answer is, you think about it. You don't take suddenly verbatim, yes, 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 very good, and I take this and tomorrow I stop doing decompression and fixation. No, that is not the, but I am giving you my experience. Professor Ha, you also listen what I'm saying. I am giving my experience, which is based on more than several publications that you are seeing, several work, and more than 400 fellows have visited me in the last eight years, 400 international fellows, and many of them are doing this operation. You see, people are happy with, some people have written that I do for lumbar canal stenosis, I do decompression and I do fixation, but the results of decompression are as good as results of fixation. I am saying, stop this decompression and try. You do fixation. If the patient does not improve, suppose you put it on me, put it on my publication. If the patient does not improve, in the third day, you can come and do laminectomy. What is the harm? Fixation is already done. You don't need to do fixation. You can do laminectomy. But I am saying that in my entire career, I have not reoperated any single patient in my lifetime. Like, I have not done decompression and come tomorrow and did fixation. So that is the thing. I know there will be several questions, Professor Ha, as you can imagine, there will be several questions and long debates. Actually, I don't want to enter into those debates. I have given my viewpoint, and I want people to listen to what I am saying. And I have invited people like you, people like other people like Benis and Dr. Oscar, and many other people are there in the audience. They have written to me, and I want to know, any other comment, Dr. Ha, you want to make?
Oh no, I just want to my chance to other colleagues because
Okay,
there are many. Yeah.
Dr. Vlad, you are there?
Yeah, I am.
Yes,
Atul,
Vlad.
I enjoyed that very much because I always like when someone is addressing the cause, not the consequences. And that's probably what you did, because it's very convincing, and I like it because it's very innovative, it's very nice, and you spent many years on that. And I just wonder how are you going to convince whole the community, because there are thousands, thousands of neurosurgeons and spine surgeons and orthopedic surgeons decompressing the neural tissues, and suddenly there is something completely different. So that's a lot of work ahead of you.
Yeah.
But you convinced me in a way.
Thank you
I
so much.
remember those transoral surgeries, you know, and I'm just glad that it's over, that we are not doing it anymore. Those were dangerous procedures. And there's another issue which I really liked is that you called the Kyrie not malformation but formation, because the malformation is completely different entity which doesn't belong here in this topic at all, and the formation it's really secondary as well as anything else. So I must tell you, I enjoyed that, and I
Thank you
believe
very
you.
much. Thank you very much, Vlad. Your words of, you know, whatever you say, I know you mean it. And if you don't like it, you can say in strong word, I don't believe in this, and I think it is completely absurd. You are capable of saying that. And you have said this on various occasions for various people. I know it. And if you approve it, Vlad, it is a big honor for me and a big, you know, it gives me good encouragement and good will to work. And I can say, Vlad, you will not regret these sentences of yours, and I will, as you were going to come to me to visit me because of Corona, you couldn't come, but my invitation stands. And as soon as we are free from Corona, you must come and visit me, and I will show you the magic of spine surgery.
Looking forward to that very much. And just
Thank you.
teasing you, Atul, how does it work with arterial hypertension and diabetes?
That also will help.
I believe so. Thank you,
Oscar,
Atul.
Oscar, you're there?
Yes, I really enjoyed your lecture. It's really a lifetime presentation from all huge experience. And certainly for the degenerative cervical spine, I think the epicenter of the problem is the facet joint incompetence. It's very different from a soft cervical disc disease. So I think your new concept has many valid points. Instability is certainly the major issue. Not many people remember this paper from Matsunaga in 76, where it shows that most of the stenotic cervical canals are not myelopathic. So you need instability to become myelopathic. So I see it all the time whenever you do posterior fixations, that the C1, C2 panels disappears, even anterior compression disappears. So this is certainly something I have seen in my practice as well. I just have some questions for you for debate. And you know, you showed different types of posterior fixation. So which one do you think it's the best, you know, in terms of results? The transfacet screw, the facet joint spacer, or the lateral mass screw? Why not to do lateral mass screw?
See, let me answer this question. Let me answer this question, Oscar, before you go to the next. You see, facets, this technique of facetal fixation is described by Roy Camille. And this technique has not been very much exploited. Not many people are doing this transarticular fixation for cervical spine. But I have done facetal fixation, lateral mass fixation. I actually, you know, with my C1, C2 fixation, I was doing lateral mass fixation for last 30 years or more. I am doing for C1, C2, of course. And I even did C1 subaxial lateral mass fixation, which unfortunately I didn't publish at that time. I did many of this pedicular fixation and screw fixation early in my career. But over the years, I have realized that this transarticular fixation, this technique is so simple, like you can do in exactly 30 seconds. And that's the end of the story. And so safe, I have never got, and so strong, the facet. So I have no doubt in my mind that facetal fixation is a beautiful form of fixation, transarticular. It is not only strong, it attacks the fulcrum of all movements. See, the movements are occurring at the facet joint, not at the body. Facet forms the fulcrum of all movement. And I use a very small screw, which is very cheap. It may not be even $1 price. You know, the problem is not the cost is not the issue. It is so simple, so quick to do. You can do multi segments at, in very quick time, and you have a very strong stability. So I prefer now even intra-articular facetal implants are used in cases where the facets are quite heavily unstable. And some cases I still do facetal, intra-articular spaces, which are described by me, which are patented by me, but I don't use it often because transarticular is a very strong fixation technique. And lateral mass, of course, I did myself. But it is not less than dangerous technique to introduce. And even with navigation, you can hit the vertebral artery and all those things. So this is safe, simple, strong, and quick.
Okay, Atul. No, yeah, it's a point. You have a point. And the other thing is, why not to do, just to go to your concept that the origin of most of these problems is muscle weakness, posterior muscle weakness. Why not to go all these techniques MIS? You could very easily do it MIS, avoid stripping all these muscles from the lamina and the spinal process. I think that's the way to go. What's your opinion?
So my opinion is, I completely agree that muscle weakness is the problem. That is my basic concept, that muscle weakness is the issue. The best treatment, Oscar, will be to tell the patient, you strengthen your muscles. You go and do exercise, jogging, you run, instead of giving a cervical collar, instead of giving a belt, lumbar belt, you ask them to do exercises. You try to avoid surgery till the last, till it is avoidable, till his muscles can become strong and his muscles can take away the load and resume the motility. So, but if the muscles are giving way and the symptoms are strong, that segment, spinal segment, has become unstable. You stabilize it, and that is the end of the whole story.
Okay, thank you.
Thank you, Oscar. And I know there are many, many questions. There are more than 100 questions on the site, and there are some, John?
Yeah, there's a surgeon that wants to show you a slide and discuss. Can you step? I lost your name here. Sir, could you step forward? The gentleman that wants to show slides and discuss a case. I'm sorry, I lost your.
Hello.
Oh, okay.
John.
Yeah, there we go. Okay. Okay.
Yeah,
go ahead.
Yeah, thanks, John. First of all, I must express my thanks and gratitude to Professor Goel. I have been immensely, what I can say, have changed my concept in the treating of a spine problem, and I frequently communicate with him with my cases that I'm doing, and also I plan to do. Here I want to show two cases. I think files.
You put share screen, share screen.
Okay, okay.
Take your time, you'll get it.
Okay. It's coming.
There you go.
Okay, it's coming. Okay. Yeah. So this 45 years old female who presented to a neurologist with the features of unsteady gait. So after imaging, the neurologist thought that it's a case of NPS. So he sent the patient to me. I examined her. She had some nuchal headache, neck pain, but she had intact memory and good urinary control. So next slide. What I have seen that the craniovertebral junction, this patient has some Chiari malformation. You can see Chiari malformation with block vertebra C3-4 and some cervical spondylosis downwards cervical. So I just asking Prof. Goel that what should I do? Only C1, C2 fixation will do for this, or I have to do also cervical fixation? This patient.
This patient will need You know, this is a young patient, you said, right?
For 55, not
This
55.
patient will need C2, 3, 3, 4, 4, 5, 5, 6, 6, 7 fixation, multi-level subaxial fixation. Dr. Salek, you must read
Yes.
this article of mine, and you
Yes.
must read, and you must see the magic of surgery. And you have to report this magic to me as soon as this magic is done by you. Okay? Now
Okay.
you show your next case. You
Okay,
answer
next
your
is that I already sent earlier to you, and I operated this case. This lady also 50 plus years having neck pain, anesthetic, quadriparesis, and
Yes.
also having she's myelopathic. You can see here. So I operated her 4 days ago. This is
First,
the
tell me, did you see the magic or no? Yes or
Yes,
no?
yes, yes, yes. So it's the
And this, tell
multi-level
this to
position.
Dr. Ha. You must tell him.
Yes, yeah. So she's happy so far, but unfortunately I couldn't upload the video for her. Once I, that's why I just show the scans and everything. Thank you very much.
Thank you, Dr. Salek. I wish you all the best.
Thank you.
You see, as you can see, these concepts are, of course, you know, will be taken over by Dr. Salek from Bangladesh, has, you know, and also from China. There are some people, it will be difficult for people, you know, who are working with insurance companies and are, you know, the instrument and implants are paid by the instrument company. Those people will have some difficulty in understanding and taking these concepts. This is my feeling, Dr. Ha. My feeling is when we are, you know, using company-made material like rods and screws and intervertebral artificial discs and all those things, which are company, you know, companies are also encouraging this kind of things. And even insurance people will not pay for the patient if you do this kind of screw fixation and all. Those people will have some difficulty in understanding this concept and taking this concept. In any case, what I want is, my dear friends, Dr. Ha, Dr. Vlad, and Dr. Mehmet Zaleli sitting here. Mehmet, you are there on the, Mehmet?
Yes, I'm here.
Yeah, Mehmet,
Welcome.
sorry for that. Mehmet is one of my most respected and most, we are going together for last 30 years together. And recently I took opinion. I was treating president of one country and I took his opinion. Now, Mehmet, there is another president waiting for your opinion and I have to treat him. And so you keep your computer on very soon. I'm going to send you his scans and he's waiting for opinion. Tell me, Mehmet, what you say some nice thing. Don't say controversial things, okay?
Yeah. Really, actually, we are many points. We are already accepting some points, but not all of them. First of all, a facetal destruction in the cervical spine may cause some kyphosis. Actually, I have seen in some of your patients in the postoperative films, they go to kyphotic position, curvature. Second thing, I must tell that in OPLL cases, I almost left the laminoplasty. I always do laminectomy plus fusion. So fusion is good because it in the long term it stops progression of the OPLL. We know that, but to persuade most of the spine surgeons, I will strongly recommend you to make comparative studies. One group with decompression, one group decompression plus fusion, and one group only fusion. Such things. Without that, it's almost impossible that we will leave our decompressive surgeries.
So what I have to say is, so I have just given you, of course, Mehmet, you know about this, all this. I have talked to you on several occasions in several meetings, but there are many young people in the audience and many, I can see questions being put up by young people and senior people, and many have liked it, many have put questions. So what I have to, by virtue of this lecture of mine, I am giving people an opportunity to really think about what I'm saying, because these concepts are all new and they are all, completely different from what the existing concepts are. And that is why I labeled my lecture as Revolution in Spine. My daughter was very angry in saying that, no, Daddy, you don't say revolution. If others have to believe, then they will say revolution. You should not say revolution. But I said that this is indeed a revolution as far as I am concerned. And this is a game changer in the field of spine surgery. And I have enjoyed this game changing for last several years. And I wish the others who can think about it more, can work upon it more, can improve upon it more, can improvise and go further. I have a feeling that there is a lot of scope for improvement in these concepts, lot of scope of questioning these concepts, lot of scope of changing these concepts. We must also know that our field is not static, it is dynamic. Transoral surgery was the most heavily done surgery in the field of craniovertebral junction surgery. I have completely abandoned for 20 years. Foramen magnum decompression was a very commonly and still commonly done surgery for at least 100 years, and I have completely abandoned for last 15 years. So there is a possibility of abandoning the existing concepts. We should keep our minds and our heart and our thought process supple and changeable. We should be moldable. We should think about what we see, and we should be, you know, understanding what we see. We should follow the literature, but we should not follow them blindly. If you understand, if you think that I am correct, you should not even then follow my concepts blindly. You should think about them. You should think about the validity of these concepts. The flexibility of your mind will determine. Don't be constrained by insurance companies and by company made implants. You improvise and you change your own implants, make them suitable for you, make them alter here and there. So that is the message. And with that message, I bid you all goodbye to you. And I want you to think about more about these issues. And John, do you have something to say?
No, that was great. A diverse following that you had, Atul, and people were able to see you in Japan. I'd like to introduce the translator, Tashi. Could you say hello for the effort you put out, Tashi? Are you there, Tashi?
Hello. Good evening, everyone. I'm Dr. Takashi Kon from Japan, Showa University, Tokyo. I'm a neurosurgeon and I'm a neuro-oncologist. As for this, there's a great honor for me to translate for Japanese participants Dr. Goel's lecture. And I reviewed a lot of papers of Dr. Goel and spine surgery, and I learned a lot by attending this kind of meeting. I'm very happy to give me a good opportunity. Thank you, everyone. I'll keep attending for further web meeting. Thank you.
Okay, we look forward to working with you.
Thank you.
Working with
Hello, Dr. Atul Goel.
Hey, Victor. How you doing, Victor?
Thank you. There you go.
Very, very nice to see you, Dr. Atul Goel. This lecture is amazing. I think it's going to revolution the spine surgery. So, congrats.
Thank you, Victor. So nice of you to be on the screen, and so nice of you to give me those comments. Victor, you are a friend. I hope my friends will give comments, and those who are even not my friends, those also will give me good comments. But the whole world is friend of spine surgery, and we have to learn and develop our art. Victor, thank you very much.
Okay, very good. We had a full house, Atul. So I'd like to thank you and look forward to doing some more of these. And thanks to all the people for coming. And we look forward to seeing you again. So have a great day.
Thank you, John. Thank you for organizing this for me. Thank you.
You're welcome.